And I'm really excited to be here because this is something that I love to talk about and that I do every day. So we're basically going to talk about the tools that we use to diagnose breast cancer, and now the latest and greatest tool that we have called 3D mammography, or tomosynthesis. As many of you probably may know, the best screening tool we have right now is a mammogram. And this really builds on the foundation of a mammogram and makes the mammogram better. We still have other tools that we use like MRI and ultrasound, CT, PET scan, but really for diagnosing breast cancer, the best screening test is still that mammogram. And now with this, combined with the mammogram, we really have increased our rate of detection. So again, I'm Dr. Grayson. I've been in Thomasville now for about 16 years. I came with my husband, who's also Dr. Grayson, who's a urologist. And I'm really fortunate that I have a great place to work. I'm at the Archbold Women's Center, and we have just a terrific team of breast cancer specialists, and it's just really a joy to go to work every day. Today, again, we're going to talk about 3D mammography, which is made by a company named Hologic. And they have been terrific in supporting all that we needed here in Thomasville to get this technology here. I want to just thank Trina Ramsey, who is the rep for Hologic, for loaning me some of the slides that you're going to see in this talk today. One of the draws of Thomasville, I think, are gatherings like this. It's really nice to have your health care close to home. I'm glad to take care of my friends and my neighbors. It's just a wonderful community. I trained at the University of Michigan in radiology, and then I did specialty training called a fellowship in mammography. And that expertise is what I bring to the clinic every single day as I work with the breast cancer team. Archbold Women's Center is very unique in that it's all under one roof, all on one site. So the technologists are very well trained, 10 to 20 years of experience, all of them. The radiologists are on site, we read the films. Then if we need to, we also talk to the oncologists in town, the surgeons in town, the patients, of course. And if the patient does need a biopsy, we do the biopsy right there. So there's that continuity of care, which in breast disease, things can get somewhat complex, and it's nice to have it all under one roof and somebody as the gatekeeper, so to speak. You may have heard about tomosynthesis in the news, but I want you to listen to this. This is sort of a summary.
Mammograms are now going 3D. Earlier this year, the FDA approved a new technology that's supposed to improve cancer detection. Now, the first women are giving it a try.
We start this morning with an amazing medical breakthrough. It's a new tool that's able to catch breast cancer at its earliest stages.
And this may be the biggest advance in breast cancer detection in 30 years. Texas Health Presbyterian Hospital in Dallas is doing 3D mammograms right now.
Now, some radiologists are hoping this may cut the number of false positive and false negative mammograms. Doctors call it digital tomosynthesis.
And there's a new imaging tool called 3D tomosynthesis.
Digital tomosynthesis.
What tomosynthesis is a three-dimensional image of the breast, and what we do is actually slice through the breast at 1 millimeter interval so you don't have the problem with overlap of tissue.
You can see through that tissue and identify abnormalities earlier and smaller than we would be able to.
We may be finding these tumors 2 or 4 years earlier than we would otherwise.
Doctors are finding trouble spots which were seen with regular 2D.
We're seeing through the tissue when it's not the years that we made in the short month that we had here. We had several cases where we found little cancers that we really believe we wouldn't have seen.
It's a final new tool in our fight against breast cancer.
Yeah, well, this is really exciting for women and their doctors because we know early detection is what saves lives.
Means that we're getting earlier detection to increase the detection of breast cancer at an earlier stage so that those women can be cured.
They caught it so early. I mean, I am so thankful because a year later, it might have been a different story.
But again, I just thought that was kind of a nice summary slide of all that's going on in the media right now. And the reason that this is a big deal is because breast cancer happens to 1 in 8 women. And so that's a very scary statistic. The risk increases significantly with age, but as we all know, for cancer treatment, the outcomes are better when we have better screening tools and when we have better treatments. The talk today is really going to focus on screening tools, not so much treatment. Again, this tool is really going to significantly change the way that we detect breast cancer. So let's talk about Thomasville for a minute. In 2014, there were 114 new breast cancer cases just at the Archbold Women's Center. My group of radiologists also cover Grady General, Brooks County, and Mitchell County Hospital, and those numbers don't even include the ladies at those centers. So this affects a lot of people that we know and love in Thomasville. Another interesting statistic is that 8 out of these women were in their early 40s, and 30 of them were 40 to 49. So that's why you got to get your mammogram every year, because it does affect younger women as well. So this is a picture of what the machine looks like, and I know most of you have probably had a mammogram. This is where the technologist stands and actually takes the pictures, and this is where the patient stands. These are the mammogram paddles, and this is the X-ray arm that actually moves in an arc over your breast. So as you know, when you have a regular, what we call a 2D mammogram, you get 2 pictures on each breast, and then the radiologist looks at that. The one limitation to that is that the normal tissue in the breast can cover up cancer, and alternatively, the normal breast tissue can sometimes look like a cancer. So, for example, if this is the breast right here, and here's the cancer, you have all these blue dots which represent the normal breast tissue. They can cover up cancers. So the great thing about tomosynthesis, instead of having one sort of thick picture to look at, you have a number of slices through the breast, and we look at them at 1 millimeter intervals. So that's a huge difference, and it separates out all of the tissue so we can simply see better. And that's why tomosynthesis is such an advance. So again, here is the basic principles of tomosynthesis, and the breast is down here. Your breast is still in compression, and then the arc basically swings over the breast in 15 degrees and takes a number of pictures, and then the computer reconstructs that and gives it to the radiologist in 1 millimeter intervals for us almost to page through like a book, is what I guess is the best analogy. So just to summarize a little bit, the limitations of 2D mammography: the breast tissue overlaps with cancers, makes it hard for us to see, and sometimes the breast tissue can look like a cancer because of other breast tissue on top of that, and tomosynthesis helps us look at these pictures in a more clear fashion. So here's another video of an actual tomosynthesis exam. This one doesn't have a lot of sound, it's mostly picture. Now, from the patient's perspective, it's going to be about the same, maybe a couple seconds longer. You still have 2 projections. And so you're going to do that first projection, where the paddle is directly parallel. But watch the arc now on the machine and see how it swings over. And it's fast. And then the next thing is going to happen is that second view that you're used to. It's going to be the same thing, but the lateral view, and the machine again is going to arc over the tissue. And the radiation is about the same as a mammogram. There's a negligible difference, but they've worked very hard to make sure that this didn't increase the dose of radiation to the breast. So then once the technologist takes all of the pictures, then it reconstructs it and then sends it to the workstation where the radiologist is. And then we page through it really just like a book, like we would a CT scan, and look through every slice of that breast tissue. Okay, so will tomosynthesis revolutionize breast imaging? It's already doing it. So some of the benefits, again, of tomosynthesis are we see more cancers. There have been some articles that say 40% more invasive cancers are detected with this technology, and that's significant. That's a lot. And also, there are times when a subtle finding is noted on your mammogram and you get what's called a callback. And it's a source of great anxiety, and we recognize that. And so you have to come in and get more pictures and try to sort through things and see what's real and what's not. And I see a lot of you nodding your heads. You've been in that chair. Now, the benefit of tomosynthesis is those callback numbers are reduced because we just see better. And so you can say, oh, yes, that really is something that we need to do an ultrasound on, or no, it's not anything, it's just breast tissue. So you see more cancer and you have less callbacks. And it also gives you better visualization of small cancers than a standard mammogram, just because you have less breast tissue covering it up. Okay, so I thought we would look at some cases. It may be a little bit difficult on this screen, but these are real cases. This is a 51-year-old female who presented for a routine screening mammogram. The 2D mammogram was read as essentially negative, but then she had, in the same visit, she had tomosynthesis on top of it. So basically what we're looking at, this is what we call a lateral view. So here's the chest wall, of course here's the breast, and here's the cancer, but on the 2D film, which is this one, honestly you can't tell that's a cancer. It looks just like breast tissue. But on the subsequent films, which are tomosynthesis, you see a radial scarring and you see pulling in of the tissues, which is called architectural distortion, and that's a cancer. And that's what we're talking about, is we see cancers earlier than we would have. Okay, here's another case. This is a 62-year-old lady presented for a routine screening mammogram. And on the 2D image, there was a questionable abnormality. Weren't quite sure if this was going to be something or not. So she ended up having tomosynthesis. And on the 2 tomosynthesis images, you can see that there actually is a small cancer forming here with scarring and pulling in of the adjacent tissues, which is what cancer does. And I'm sorry, it doesn't project real well. Some of these other pictures I think will be better. Okay, this is a younger woman. This is a 30-year-old woman, and she has a density right here on her mammogram. And so what we did is we did magnification views in 2D, and we see it again here, but then she had tomosynthesis. And now this is what the cancer looks like. And it's amazing. I mean, you can measure this, you can really describe this, and that's what it looks like on a standard mammogram, which is a lot tougher to figure out, is that something? Is that just breast tissue? Is that some scar? Or is that a cancer? So this case really demonstrates, you know, how much better this technology really is. Okay, so this next case we're going to talk about is a lady with implants who came in. And so the first picture here, this is a lateral view, and this is the chest wall right up here. This is the implant. And anytime we do implant views, we take pictures of the implants, make sure that they're in the right position, they're not ruptured, Just make sure that they look the same as they did the year before. And then what we do is called an implant displaced view, where we gently push the implant out of the way and image the breast, because the implant will compress the breast tissue and we want to be able to see through it. So we push the implant out of the way and then we image. And on the 2D, you see something right there. Again, something that you would get called back for ordinarily. And this lady had a tomosynthesis exam and had this picture here. And we looked at it a little bit closer, and then we see the cancer again. And then again right there. And then there's the cancer in that 2D. And actually, that's a 2D and that's a 3D. And you just see things so much better than you ordinarily would have. Now, if you have an abnormality such as this, you wouldn't get called back. We would talk to you right then and say, this is what needs to be done. And a biopsy would need to be done, and then we would go ahead and set that up. Okay. Now, this is also an interesting case, sort of similar to the other ones. This is a craniocaudal view. This is the nipple right here, chest wall is back here. And again, there's an abnormality in this breast. But when we did the 3D pictures of her, it's gone away. There's nothing there. This is breast tissue. So she didn't get called back. She didn't need an ultrasound. You know, good exam, we'll see you next year. And that's what you want to be able to say. Okay, so here, what I wanted to do is, there's a really nice summary of what tomosynthesis is that I went ahead and put in here because I think it just sums it up so well, and I'd like to show that to you. Anyway, I thought that was just a really nice summary of how this technology works. One thing we didn't talk too much about as far as benefits are false positive and false negatives. A false positive is when the test indicates there's cancer, but there is no cancer. And a false negative is when the test indicates there is no cancer, but cancer is present. So you want to decrease both of those. You want to increase your accuracy. You want to say, when I think there's a cancer, there's a cancer. And when I don't think there's a cancer, there's not a cancer. So that's why decreasing false positives and decreasing false negatives is so important. It really is revolutionary technology, but it's really based on very good technology to start with, which is a mammogram. And mammograms is an excellent technology, but boy, this is it's just better. It's just kind of it's the next step. And we're very excited that we're going to have this at Archbold very soon. And the way I kind of look at it, this is, as many of you may know, this is the Louvre. This is a very famous museum in Paris. And this structure is a glass pyramid, which is ultra-modern, placed on the foundation of this very old museum. The museum was built in the 12th century. And every generation adds something to it and makes it better. This is just the most recent example of really the merger of the old and the new, but combined is even better. And I think that's a good analogy for how tomosynthesis works. It doesn't mean the mammogram's bad. This just makes it so much better, is the way I like to look at it. So what questions can I answer for you? Yes, ma'am.
Will tomosynthesis be the standard when you start doing it?
Yeah. Yes, it will be the standard. Yes, ma'am. And in fact, once it's installed here, we're actually taking out the other units. Yeah, I think it's that good. I wouldn't want to have somebody getting the 2D and then somebody getting the 3D. So we're going to take out all of our other units and put these in. Absolutely. So it will be the standard.
So you're not using it as of this month?
We're using our regular mammograms now, and tomosynthesis is coming this spring. Yeah. Exactly. It'll be this spring. They have to order it and install it, and yeah. I wish it were tomorrow.
I gotta get mine.
Yeah. Now the thing is, but I still want everybody to get their mammogram because, we do detect cancers in women that miss a year, and I don't want to, I'm having my mammogram this month too, so I don't want to discourage anybody from not getting it.
Oh, no, I'm gonna get it, but I just hoping you can.
Yeah. Yes, ma'am. I hope to. I hope to. Generally what we do is we start it here at the breast center and we get everything going and up and running, and my hope is to have it in all of the affiliate hospitals. Absolutely.
And then I'm on Medicare. Does Medicare, I'm assuming this is a greater cost.
It is. It is a little bit greater cost, but it is being covered by local insurance companies and by Medicare. Mm-hmm. Absolutely. Yes, ma'am.
I thought there was a digital form of doing mammograms, is the tomosynthesis going to take that place?
Say that again.
I thought there was also a digital way of doing mammograms.
Oh, okay. That's a very good question. She's asking, is Archbold Hospital doing digital mammograms? And the answer is yes. In fact, we're doing digital mammography throughout all of the Archbold facilities. And this is actually, tomosynthesis is digital. So it will basically interface with your regular digital mammogram. But yeah, that's a very good question. Mm-hmm. Mm-hmm.
My question, if you have mammograms on at the short term, would they be involved with the new technology, or
you know what? I don't know, honestly. I'm just associated with the Archbold Women's Center. I don't honestly know the answer to that. So, yeah, I don't know.
Another question.
Yes, ma'am.
Is there anything for the comfort that is being improved?
I know that. That's a really good. I know.
And you could purchase, because it normally wasn't covered by insurance, very minimal, $5 for this additional pad that was
Yeah.
put on the plate, and it did make it more comfortable.
Right. Now, we actually do, yeah, I know what pads you're talking about, and we tried the pads, and we still have the pads. I know exactly, they're basically a thin pad that goes on the paddle before you have your mammogram. Actually makes it a little bit less cold, too. And so we had those, and then there wasn't much positive response from it, but I'll bring that back to the center and say that this lady wants to have the pad on her mammogram. So yeah, I know exactly what you're talking about. We try to do the mammograms as quickly as we can, and as soon, now in this new machine, with this new generation there, it's even going to be quicker, even with the ARC, because as soon as it's done, it releases. Mm-hmm. Yes, ma'am.
We all know that men have breast cancer.
They do. Mm-hmm.
Also.
Yes.
What time of outreach do you do for them?
Well, you know, that's a very good question. I think we probably need to do more. There are male breast cancers, and we do see it here in Thomasville. We don't generally have men come in unless there's a problem, and they generally will see their doctor for it. So I do a fair number of male mammograms. It's not like as common as women, obviously, but we do see it. But you're right, we probably need to do some more outreach for that. That's a very good point.
Where is the nearest facility that has this technology?
They have it in Tallahassee and I think possibly Valdosta. Yeah.
I've heard, now I'm a breast cancer survivor myself, but I've heard that this technique, once you've had breast cancer, they can more easily detect any reoccurrence.
For the same reason, because the breast is sliced and you can see through the tissue better. So yes. So in the mm-hmm. Yes. Mm-hmm. Mm-hmm. Because you just see better. You just see the tissue better. So yeah, you're absolutely right. Mm-hmm. Yes.
Does menopause or weight gain increase your chance of breast cancer?
Does
menopause or weight gain increase your chance of breast cancer?
Weight gain is associated with breast cancer because there's more estrogen. And estrogen seems to play a role in the development and growth of cancer, female cancers. And so that's where the association is with weight gain and cancer. It has to do, it's a hormonal thing. It has to do with estrogen. And as far as menopause, generally, while the risk of cancer is higher as we get older, the cancers tend to be less aggressive, if that makes sense. So if we have a younger woman with a cancer, those cancers can be more aggressive than, for example, if we're 80. So it's hormonal, they think. A lot of it's genetic, too. It's a tough question, actually, because there's a lot written on that, and there's some disagreement, to be honest with you. But yeah, I've read that, too, in many, many articles about a patient's weight and their risk of breast cancer. And generally, when you look at large populations of people, there is an association with weight. But it's because of the estrogen levels. Yes, ma'am.
Fibrous breasts.
Uh-huh.
Does that make it more painful for the mammogram?
Well,
The pain is coming
yeah, that's a good question. What she's asking is when you have fibrocystic disease, which is basically cysts and calcifications and breast pain, it's sort of a whole syndrome. And most of those ladies have more breast pain than the general population. And so the mammogram can be a little bit more uncomfortable. Yes, so the pads come in, I think, to help a little bit. Yeah.
I wouldn't even see where the pad would help you because
It's just, you're still in compression, you're correct. But it does make it maybe just a little bit softer and a little bit less cold.
I have
Yeah.
another question.
Mhm.
When you showed the photos of the breasts up there,
Uh-huh.
you'll see some areas that were like really white.
Oh, okay, that's,
What is that? Do you see the difference there?
yeah, I should have gone over that. When you look at the breast, the fat is dark and the breast tissue is white. And so breast tissue is not smooth and soft. It's very lumpy, bumpy, lobular, and that's what mammograms look like. And so you basically, the breast is made up of fat and breast tissue, and the white is the breast tissue.
So if you have
Yep.
larger breasts, you have more of the...
Not necessarily. Not necessarily. As we age, generally, the breast becomes more replaced because we're not breastfeeding, we're not having kids. And so postmenopausal mammograms are easier to look at because they're becoming fatty replaced.
Not the breast tissue.
Yes. Less breast tissue, more fat with age. Yeah. Yeah. Yes, ma'am.
So if a person has fibrocystic breast disease, is it harder to detect cancer?
Not necessarily. Her question is, if you have fibrocystic disease, is it tougher to detect cancer? I guess the answer is sometimes. That's really the answer, because those patients tend to have more cysts and more calcifications that we need to look at and sort through. So it can be sometimes a little bit more challenging, but, you know, it doesn't make it so that we can't detect it. Yeah.
Are you more prone to breast cancer if you have fibrocystic breast disease?
No. Mm-mm.
There's
No.
correlation.
No, nothing that's firm. Mm-mm. I mean, we wouldn't image those women any sooner, for example. We wouldn't image them any sooner than 40. Yes, ma'am. We would still start at 40.
I mean, start out a person who started when they were 10 or 11.
Well, there's not any firm data on that. There's not any firm data. Yeah. 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 You know, there's some studies that suggest maybe a little bit more risk, but nothing statistically significant. Yeah.
What age should a woman with factors, family factors, inherited start?
Yeah.
Because I had a friend that was diagnosed at the age of 32 only
Yeah.
because she took her aunt in to MD Anderson for treatment.
Yeah, yeah.
And they suggested that she had one because it was so close in family. and
Yeah.
They detected it at age 32.
And she had the BRCA gene. She was positive. What she's talking about is, when do you start doing mammograms earlier than 40? And if you have genetic testing and you're shown to be at high risk, and if you have that positive gene, you have about an 80 to 90% chance. And so that's significant. So we generally start those women at 30 and just start.
She didn't know she had the gene until her aunt was diagnosed. and
Exactly.
She took her in for her second or third treatment.
Yeah.
And the doctor said, wait, you had a mammogram.
Yeah, yeah. And even if you haven't been genetically tested, if you come in and say, boy, I've had pretty strong family history, we get you in. You know, yeah, absolutely. Because there's not a downside to me. Yeah.
I'm the third in my family to be diagnosed with breast cancer, so we haven't done the rapid testing yet, but I have a ton of granddaughters. And so how early can they be tested? I know you just said 30.
You mean for mammograms or for the genetic?
Yeah, around 30, but genetically, could they be tested now?
I just had that.
Did you?
It's a simple blood test.
Yeah. I don't know if there's an age. I don't know the answer to that, actually. Is there an age that you have to
Not that I
be?
researched. I mean, if
Yeah.
you're high risk, so a mother, an aunt, a grandmother, anyone in your direct line, you're considered high risk. So I was 22 when I got it done. So
Yeah. But I don't know if there's an age that you have to be tested. I guess that's a good question. I don't know the answer to that.
So it would show up at a young age. If
Ma'am?
you took the test, they would detect it at a very young age. Or could detect it.
because it's in your DNA.
Yeah.
So they could detect it at a very young age.
I would think so. Where did you have it done?
In St. Petersburg.
St. Petersburg, okay.
Do they do that testing here? I know they do it in Tallahassee.
I can check with the oncology center. I think that they are doing it. We don't do it where we do the mammograms, But I'll check with Debbie Beeson. She'd be a good one to ask. And I will find out where and how they're doing that. I know we have a lot of patients that get it done. And we have sent them to the cancer center and they set everything up for us. Yeah.
Well, I'll see Debbie next week.
Oh, you will? Okay. Yeah, that's,
I'll take one thing off the plate.
Yeah, exactly. Okay. Yes, ma'am. Wow. Right. You know, it is very expensive. That's, yeah. And I guess it depends on the extent of genetic testing too. There's a lot of genetic testing you can do, and then there's female cancer specific genetic testing. So it depends on how extensive you get. But, you know, it's an individual decision. It really is. But if you have enough family members in a direct line that are female, that have female cancers, probably worth having it done.
I've also heard that if you get breast cancer beyond age 60 or 65, that is not an inherited thing.
Not necessarily, that's true. And I would say this, the vast majority of women, we diagnose cancer and have no family history at all. So, you know, if you have family history, I note that, but I'm aggressive no matter what. I'm aggressive whether you have a family history or not. Because like I said, most breast cancer patients do not have a family history. Yes, ma'am.
I have a suggestion, it's not a question.
Yeah.
I had the lumpectomy, and I tried to have reproduction to fill in that hole, but it only made more scar tissue. So I would recommend leave the hole and just wear them. You can wear the filling in better than I would have had to go through all these. Now they having to do 2 mammograms, a lot of to see what's going on.
Yeah. What she's talking about, unfortunately, she had a lumpectomy, but then had reconstruction on top of it to try to have a better cosmetic result, right?
Right.
But then ended up having some problems related to the treatment of the, you know, trying to get a better result. Yeah, I know. We do see that. Yeah. I know it. I know, and you're already going through enough anyway. Yeah, exactly.
17 years away.
Well, that's awesome. That's awesome. Oh. Yes, ma'am.
I have one more question on the
Uh-huh.
breast. Is that hereditary?
We think, yeah. You know, I think it is because I have mothers and daughters and aunts, and they all look very similar on their mammograms. And so, you know, I've been doing this a long time, and it seems to be genetically linked. It probably is. Yeah. Anything else I can answer for you?
Yeah, what makes the breast fluctuate when you go get a mammogram?
Makes it what?
Fluctuate. Sometimes once I went and got a mammogram, then I had to go back and get a second check.
Well, that's because they saw something. That's called a callback. So we saw something that we needed to get more pictures of, and maybe magnification pictures, or maybe an ultrasound. And sometimes it's just that overlapping tissue, and you can't see through it well enough, so you have to bring the patient back and take some more pictures to clear it. Yeah. Yeah. Anybody else? Well, I just want to really thank everybody for coming here. The questions were great. I know there's a lot of interest in this disease that has affected, you know, practically everybody in this room. But thank you for your time. And if you have other questions, I'm going to stick around for a little while. I'll be happy to answer them.